So our speaker today is Professor Lynne Turner-Stokes, who is Norfolk Park Professor of Rehabilitation and also based here in the Cecily Saunders Institute. I work closely with Lynne up at Norfolk Park, so I'm declaring my conflict of interest. Lynne, you can see Lynne's topic for today. I'm going to let Lynne lead us through that. Thank you very much.
Thank you very much for that nice introduction. Thank you for inviting me to be here, and it's lovely to be here on a lovely spring afternoon, the first that we got. Now, the interesting thing here is whether I can get this to move on, because it doesn't seem to want to at the moment.
Yeah.
What am I? You're doing that one. Okay. Fine. So yes, I've just been introduced, so that's fine. So we'll kick straight up. So we get ever better. You're right.
I'm just going to mute more.
That as well. Okay. Thank you. We get ever better at saving lives through better emergency acute care services, trauma networks, hyperacute stroke units, defibrillators in public places, and those give us improved outcomes. We rescue people who would have died at the scene. But some of those will have catastrophic brain injury and they'll remain in a prolonged disorder of consciousness. So the modern day doctor's dilemma is what happens when it becomes clear that a patient won't regain the quality of life that they themselves would value. How do we manage expectations and difficult decisions? And how do we humanely and legally discontinue unwanted further treatments when they're no longer in the patient's best interests? No, it's frozen again. This one. No, that's gone back. We'll try click.
There you go.
Okay, we'll do a click on the mouse. Okay, no, we won't. Okay. So in the early stages following injury, the prognosis for recovery can be hard to predict, and we institute a range of life-sustaining treatments in the hope of getting a good recovery for that person. The purpose of that treatment is to keep them in the best possible condition in the hope of a recovery to the quality of life they themselves would value. Unfortunately, the longer they remain in PDOC, the less likely they are to regain consciousness. And regaining consciousness isn't always a good thing if the patient then becomes more aware of being in a situation that they themselves would find intolerable as a result of experiencing pain and distress and so on. So we start from the strong presumption that it's in a patient's best interest to continue to give life-sustaining treatment, but that presumption can be rebutted if there's evidence that the patient wouldn't want it. A problem for us as clinicians is that we're programmed to save and preserve lives. We often continue treatment by default without even stopping to think whether the patient would want it, or even about the legal basis on which we're giving the treatment as opposed to withholding it. There's some common beliefs amongst both health practitioners and the public, such as not giving medical treatments is tantamount to neglect, or that stopping a life-sustaining treatment is hastening death. Neither of those things, of course, is true. So the objectives for this talk are to explore some of the ethical and practical challenges at the interface between rehabilitation and palliative care. We're going to look at some of the range of life-sustaining treatments that are given along the pathway for catastrophic brain injury. We're going to look at some of the legal procedures and frameworks that govern decision-making, how decisions are made, who makes them. I've got some practical guidance on how to go about decision-making for life-sustaining treatment, 10 steps to manage that appropriately and safely within the law. We're going to look at management at the end of life after treatment's withdrawn, and I'm going to share some recent experience of some court cases in this area if there's time, which I hope there will be. So we sometimes forget the legal basis for providing treatment, but it's straightforward, and it goes like this. A person goes to the doctor makes the diagnosis, decides what treatment options should be offered, presents the patients with those options, describes the potential benefits and the likelihood of success and also the possible risks. And then the patient, the person, weighs up those pros and cons, decides which, if any, to accept. If they lack capacity to do that for themselves, then treatment decisions need to be made for them on the basis of their best interests. And in England, the Mental Capacity Act 2005 sets out the framework for that best interest decision making. So it sets out some statutory principles. Statutory means you must do them. Statutory principles for making decisions on behalf of patients who lack capacity to decide for themselves, for weighing up best interests, usually in a balance of benefits and harms. It brings us, of course, the two-stage mental capacity test. Is there an impairment of the mind or brain? Does this affect their ability to understand, retain, weigh up information in order to make a decision and then communicate that decision? And it also provides provisions to support decision-making that allow an individual to influence future decisions about their care in the event that they should lose capacity. And in England, the legal execution of the Mental Capacity Act, disputes under the Act are adjudicated by the Court of Protection for serious medical treatments. In those proceedings, the court, the COP judges are empowered to make best interest decisions and to declare that a proposed course of action by a health professional would be lawful, or as it's often put, not be unlawful. It protects the patient's interests, importantly, but it also protects clinicians from prosecution in the event of a patient dying. And the official solicitor is appointed in most of those cases to represent the patient as their litigation friend. So who decides what's on offer? It's, first of all, and this is fundamentally important, I'm sorry, I'm going to go on about it because everybody forgets it. It's important, it's up to doctors to decide what treatment options are on offer. There might be a number of reasons why treatment may not be on offer, which would include the risks of the treatment for that particular individual in the light of their other conditions, the lack of evidence for effectiveness, or even sometimes resources. Those are all valid reasons for not offering a treatment. And a futile treatment is a medical intervention that doesn't lead to an improvement in the patient's prognosis, comfort, well-being, general state of health, or quality of life. And all treatments can, of course, cause harm, and a futile treatment is one that has no benefits. Importantly, and I'll say this many times, neither that patient, nor their family, nor even the Court of Protection can demand a treatment that's not on offer. They can't force a doctor or a hospital to deliver a treatment for which the harms outweigh the benefits. But for treatments that are on offer, a patient who has capacity can decide, as I mentioned earlier, whether to accept them or not. Before losing capacity, they can plan ahead. They can draw up an advanced decision to refuse treatment, not to demand treatment, but to refuse treatment. They can appoint a lasting power of attorney for health and welfare and instruct that person what they would want in the event that they lose capacity, and that can include decisions about life-sustaining treatments. After losing capacity, the court can appoint a welfare deputy to make decisions on their behalf, but that welfare deputy can never make decisions about life-sustaining treatments. If none of those are applicable, which is usually the case, sadly, then responsibility for best interest decision-making ultimately lies with the senior clinician in charge of the patient's care, which is usually the consultant. But any treatment that's given to a patient who lacks capacity can only be given on the basis that it's in their best interests. That's based on the balance of benefits and harms, but importantly, taking into account their likely wishes so far as those can be known. So we trot that out, and I'm sure you've heard it dozens of times. You do it in your mandatory training all of the time. But what exactly does that mean in clinical practice? What it means is that doctors should have a reasonable expectation that any treatment they're going to give would do more good than harm, and that the patient, him or herself, would want to have it. And importantly, we have to remember that it's a giving and not the withdrawing or withholding treatment that needs to be justified. But just because you can do something doesn't mean to say you should. And the decision-making must take into account what that patient would have wanted, so far as we can establish that. So families and friends must be involved in the best interest discussions. They still can't demand a treatment that isn't on offer, but they can tell us something about the person's values and beliefs and anything they might have said that might give us a clue about what the patient might say if we were able to ask them themselves. There's a range of treatments to consider, and I've divided them into two groups. There's the escalation of unplanned interventions, so things like cardiopulmonary resuscitation, CPR, in the event of a cardiac arrest, escalation to intensive or high dependency care, acute medical treatments such as antibiotic fluid resuscitation if you have an infection, acute surgery, neurosurgery, shunt procedures, procedures for bowel obstruction, lots of things that might happen, and particularly happen out of hours when there are no members of the treating team around to know what the plan is for that patient. They have to be dealt with by teams who are unfamiliar with them. So we draw up treatment escalation plans. in order to be able to communicate that to the people who are caring for them after us who are not familiar. But importantly, also, as a team, when we draw up a treatment escalation plan, that means we do it collectively and we don't leave one particular consultant responsible for executing that plan just because they happen to be the person on duty. And that's really important to share that load. So those we all know about, we think about those, but we don't think much about the elective medical interventions, in particular things like prophylactic treatments, prophylaxis, vaccination, screening for cancer. We think a bit more about long-term treatments such as insulin for diabetes, dialysis or tracheostomy or ventilation. And we think quite a lot about tube feeding, but actually we need to think about all of those things and think about them both individually and together in the context of the whole patient. And when I talk about tube feeding, I'm talking about temporary route tube feeding, so through a nasogastric tube, or establishing a permanent route via gastrostomy. Now, this is probably the most important slide, actually it's the second most important slide, so I want you all to wake up and pay attention at this point, because this is the framework that we work on for decision making. So as I said, it's first up to the clinician to decide if a treatment's on offer, and that's usually on the basis that it's likely to do more good than harm. If it's not on offer, we go down this pathway. It's usually on the grounds of futility. Neither the patient nor the family, nor even the Court of Protection can demand that treatment. It's not a matter for best interest decisions. Best interest don't come into that. Only if the treatment is on offer, then you have to do a best interest decision to discover whether the patient would want to receive that treatment. So we need to know who's the decision maker. Is there an ADRT? Is the lasting power of attorney for health and welfare? And if not, then the senior clinician must decide on the basis of best interest, taking into account the patient's likely wishes. Obviously, we can get into dispute about this, and there are different legal processes for managing these two arms of the pathway. So a serious medical treatment involves treatments or procedures that have profound or long-term or life-altering consequences. If a serious medical treatment is on offer, but there's disagreement about whether it's in the patient's best interests, and that can't be resolved through discussion, that must, not should, must be referred to the Court of Protection if it can't be resolved. And the treating organisation or commissioner is responsible for making that application. But as we said, the Court of Protection can only make decisions that the patient, him or herself, could make. It can't force a clinician or trust to give a treatment that they consider to be clinically inappropriate. It can only choose between two or more options available on the basis of the patient's best interests. If a treatment's not on offer, then disputes can be dealt with by a different court route. That's in the High Court, usually by the Administrative Court by way of a judicial review. In that case, the family is responsible for bringing the application, but they must be informed of their right to do so. So going back to our tree, we've got that pathway and we've got the disputes on this side dealt with in the High Court and this side dealt with the Court of Protection. The most frequent mistake that I see, and if I had planned for every time I see this in people's notes, I wouldn't have to work again. The most frequent mistake is people say the treatment's not on offer because it's not in the patient's best interests. Those are the wrong, that's modelling the pathway. And yet people write it constantly because clinicians have got this thing, best interest now, but they haven't understood the difference. And then the problem is we get into a muddle when there's a dispute about which court we're going to go to. And I've spent many happy hours in courts arguing that very same thing. For those treatments that are elective decisions, best interest decisions about life-sustaining treatment, there's some very helpful advice that came from Justice Cobb, Mr. Justice Cobb, in the case of PL versus Sutton Commissioning Group. And the key questions, he said, you need to ask is what's the patient's current condition? What's their awareness of the world around them? What's their quality of life? What's their positive experience? Is there any enjoyment in their life? How can we maximise that? Is there a negative experience? Do they experience pain or distress? Is that being appropriately managed? What's their prognosis? What's the best and worst case scenario for recovery? And would that represent a quality of life that they would value? And then what would happen if the treatment were to be withdrawn? What would the end of life care look like? Where would it be provided? And I'm going to come back to these three key principles because they're really important. We start from the strong presumption that it's in the patient's best interests to prolong life, but we can rebut that if there's evidence they wouldn't want it. The decision no longer rests on whether they'll regain consciousness, but whether they've regained a quality of life that they themselves would value. And those are very, very different things. And finally, as I said before, and I'll say it again, it's the giving, not the withdrawing of treatment that we have to justify. As clinicians, we often think about that the other way around. So tube feeding is a little bit of a special case because, as we know, many people with prolonged disorders of consciousness are unable to swallow, and they require tube feeding, otherwise known as clinically assisted nutrition and hydration. When that's withdrawn, it's more emotive because unlike CPR or treatment for an infection or escalation to HD or ITU, that might or might not happen. But if you stop tube feeding, they will definitely die within 2 to 3 weeks. So that does raise the stakes a bit for us emotionally as clinicians as well as for families and patients. So since 1993, CNH has been classed as medical treatment, but to many people, giving food and fluid feels like part of basic care. Withdrawing tube feeding is therefore probably one of the hardest decisions a clinician ever has to make. And decisions to withdraw CNH in patients with prolonged disorders of consciousness have therefore been treated differently by the law compared with other life-sustaining treatments. I'm going to quickly run through the legal background to that. So it started off in 1994, the case of Airedale versus Bland. Tony Bland had been in a persistent vegetative state, as it was called in those days, for 4 years. The House of Lords agreed that it was lawful to withdraw what was then called artificial nutrition and hydration on the grounds of futility, but they said that these were finely balanced cases and future cases must always come to court. So the next 70 or so cases came to the court, and provided it was demonstrated that they were in permanent vegetative state, then it was agreed that CNH could be withdrawn on grounds of futility. But we couldn't withdraw CNH, for example, in a patient in minimally conscious state, at least not until 2013, when we had the case of Aintree versus James. This was a gentleman in permanent minimally conscious state, had been 18 months in critical care. He also had carcinoma of the prostate. So the Supreme Court allowed withdrawal of all life-sustaining treatments in his case, but it said that the focus should be on the quality of life that he himself would value, not on consciousness. So in 2016, we had the case of Briggs versus Briggs. This was a gentleman who was in minimally conscious state quite early on, actually making progress towards recovery, might even emerge into consciousness. And the court in that case found that it was lawful to withdraw, even though he wasn't in permanent MCS and he might regain consciousness, because he still could never recover a quality of life that he himself would value. His wife said that he was somebody who was he was actually policeman chasing, I think, robbers up and down the motorway on his motorcycle, and his wife said he couldn't go back to riding his motorcycle and doing his job he loved. Life wouldn't be tolerable, and that was agreed. So this bar for quality of life varies hugely for different people, and we have to take that into account and really understand that. Then in 2018, we had the case of an NHS Trust versus Y, again in the Supreme Court. This case we took to the court not asking whether it was lawful to stop the tube feeding, but whether it was actually necessary to go to court, because there had now been so many cases coming through that we really wondered whether they always had to go to court. And it was agreed that there was no longer any need to make that application to withdraw CNH through the court, so long as all parties were in agreement about the person's best interests and the relevant guidelines have been followed. So what guidelines are those then? The guidelines, we have 2 sets of guidelines that set out the process by which you can responsibly and robustly make these decisions together with the clinicians and the family without external scrutiny by the court. We've got the RCP BMA guidelines, which are endorsed by the GMC, which related to decisions about tube feeding specifically, but in any patient who lacks capacity, not necessarily people in prolonged disorders of consciousness. And then we have the national guidelines for prolonged disorders of consciousness that addresses decisions about any life-sustaining treatment, but only in patients with prolonged disorders of consciousness. But it gives very practical advice for decision-making, including protocols for end-of-life care, which are useful in patients who aren't in PDOP. So both guidelines take a broadly similar approach, which is the extent of the safeguards to decision-making has to be proportionate to the consequences of the decision. So we need to know about the prognosis for recovery or deterioration and the likelihood of them achieving a quality of life that they would value. So we have to understand what that value quality of life would be. We need to understand their expected survival time if CNH were continued, and then we have to look at the certainty with which those can be predicted, because we need to understand the impact of making the wrong decision, and that wrong decision could involve depriving a patient of a life that they themselves would value, or equally forcing them to live a life that they wouldn't have wanted. There are certain things that aren't covered by the guidelines, including when it's not possible to give tube feeding, it's not clinically indicated, patients are expected to die within hours or days, or it's part of a broader decision-making process that covers other life-sustaining treatments as well. Following the changes in the law, we have the sections 4 and 5 of the guidelines that set out this practical guidance for responsible decision-making by clinicians, including decisions for withdrawal of CANH. There have been concerns amongst health providers. How do we know when we've done it right? We do all of this decision-making, but have we done everything we should? How do we know we haven't missed something out? The guidelines provide practical tools to support those discussions and the documentation, normalising discussions with the family about things like treatment escalation, CPR, clinically assisted nutrition, hydration should routinely be done. There's a statutory requirement. You can't just push it under the carpet, leave it for somebody else to do. You actually have to do it yourself when you've got a patient there. If you're giving anybody, you're giving tube feeding to, you writing up their tube feeding every day, it's your responsibility to understand whether that's what the patient would want. There's a pro forma for documenting the process, and then there's protocols for palliative and end-of-life care following CNH withdrawal. And the safeguards that are there, we need to have a formal assessment of their level of consciousness, and that needs to be conducted in line with the guidelines and the prognosis established by a PDOC expert physician. And that's really important because we need to understand what the best and worst case scenario is. We need to have our best interest discussions that have been properly conducted, having all the relevant members of the family and close friends, and they have been then informed of that best and worst case scenario for recovery. All parties need to be in agreement about the patient's best interests. A second opinion needs to be obtained from somebody independent who has not been involved in the patient's care, and at least one of the consultants involved has to be a PDOC expert physician, and there needs to be a clear plan for palliative care following CNH withdrawal, setting out how and where it will be managed. So there's quite a lot to cover in that situation, and it's designed really for people who've been in established prolonged disorders of consciousness. But of course, you can't do that in every single case. Patients may happen to be in prolonged disorder of consciousness, but have other comorbidities. They may have unsurvivable brain injuries, and they're never going to be able to leave hospital, not even stabilise them sufficiently for assessment. Some have bowel dyskinesia due to their brain injury with vomiting and aspiration. Enteral feeding simply isn't possible. So we may have to make a clinical decision not to offer treatment. And that's a situation where families need to be informed of the decision and the reasons for it, and informed of their right to challenge it via the High Court. The guidelines set out, quite helpfully, I think, some categories for external scrutiny, depending on that prognosis and uncertainty. So category 0, you've got a valid applicable ADRT that the patient said, no tubes, I don't want any tube feeding if I have a brain injury and remain unconscious. That's legally binding if it's valid and applicable. So in that case, we don't need any best interest decision making. The patient themselves has already decided. And similarly, they may have instructed a lasting power of attorney. Category 1 then is that death is imminent. They're dying within hours or days, or tube feeding is contraindicated, or it's withdrawn as part of an established end-of-life care programme. Then we need a second consultant involved in that decision because it's a serious decision, but they can be from within the same department. Next group is people with comorbidity and frailty, likely to last more than a few hours or days, but not more than a year. And in that situation, we need a second consultant, ideally from a different department, but can be from the same organisation. When we move to elective CNH withdrawal in people with prolonged disorders of consciousness who are likely to live more than a year and actually may live a decade or more, then we need a more robust decision making. So we've got categories 3 and 4. 3 is where there's a high certainty about their prognosis, low level vegetative state, they've been in disordered consciousness for a long time, and then less certainty, they may be still progressing, there may be some recovery. So those are different categories, broadly the same thing required. We need a senior consultant outside of the organisation. At least one of the consultants has to be a PDOC expert physician, and the guidelines for assessment and best interest discussions all need to have been met. So if at the end of that process there's still disagreement about the patient's best interests, then you have to make an application to the Court of Protection. 10 key steps I'm just going to summarise therefore for keeping out of trouble and concentrating on making these decisions safely to make sure that we really thought about them properly for the patient, because it's so important to get this right. So first, we decide that treatment's on offer. If it's not, we justify and document the reasons. If it's not on offer, we inform the family, explain why it's clinically futile. If we're not offering treatment and that is disputed, then we'll probably seek an opinion from an independent consultant, see if somebody else would be prepared to offer it. And if so, facilitate the appropriate referrals to pass them to their care. And we need to inform the family of their right to make a legal challenge. If the treatment is on offer, then does the patient have capacity to decide? We need to document the mental capacity assessment, a 2-stage test of capacity. If they lack capacity, decide who's the best interest decision maker. Is there an ADRT? Is there a lasting power of attorney? And otherwise, it's the senior clinician. But we have to remember that the treatment can only be given if it's on the basis of their best interest and in line with their likely wishes. We have to do that best interest discussion with the family. So we conduct the discussions with the relevant people, family, friends. They don't have to be blood relations. The next of kin doesn't have any superior decision-making power. Sometimes friends know more about what the patient would want than family if they've not been particularly close. We have to make them aware of the prognosis, with and without the proposed treatment, the best and worst case scenarios for outcome, and draw a picture of what that might mean in real life. So this patient may survive for 10 years, but they're always going to be dependent, they're always going to be in a nursing home, they're always going to need to be cared for by other people, and they may have minimal awareness of their surroundings, and they may also have increasing pain from spasticity. So we need to talk about all of that, not just brush it under the carpet. So we explore also the patient's previous values and beliefs, anything they might have said. If they watched a TV programme, gosh, if I'm ever like that, I don't want to be in a nursing home, those sort of things. We need to know that. We have those discussions. It's an iterative process. You can't do it in a one-off. You have to keep on coming back to it. And then if everybody's agreed, actually, is there somebody else who take a different view? Do we know we've consulted the right people? As we've said, if the patient's a PDOC, there are those additional safeguards of the assessment, the expert physician, and appropriate independent second expert physician from a different trust. And we need our palliative care end-of-life programme drawn up as a written programme. And then if there's still disagreement about best interest, at the end of that, that's where we need our court application to the Court of Protection. But actually, that whole process we've been through will really help distill the arguments for that process, so that the judge can actually see what those arguments are and actually be able to make a judgment on it. And then number 10 is I do recommend choosing a team with the appropriate experience. Not everybody has experience of managing these cases. It's quite a niche area within legal practice. So you want a barrister and solicitor who have really been here before, rather than somebody that's new to the area. So talking briefly about planning palliative care. Patients are likely to die differently. Sorry, that's a silly thing to say to people who are palliative care, but of course you know that. But sometimes we do forget. So depending on the nature of their life-threatening condition, when treatment's withdrawn, we're going to expect different types of symptoms. So, for example, if they were stopping insulin for diabetes, they're going to have maybe ketoacidosis or hyperosmotic coma will normally die within about 48 to 72 hours if they're totally insulin dependent. Dialysis, they're going to die of uremia and acidosis in an average usually of 1 week, but it might be between 0 and 6 weeks, depending again on how dialysis dependent they are. May also depend on other comorbidities. Tracheostomy, they have aspiration pneumonia, respiratory failure, that's a variable length of time, and long-term ventilation, likely to have type 1 respiratory failure. It could be instant, but it could be hours, it could be days. So we need to plan for the duration over which we need to provide the palliative care. And then in CNH withdrawal, as I said, multi-organ failure secondary to dehydration is likely to take 2 to 3 weeks. So our planning must take account of that likely nature, the expected timescale. People in categories 1 and 2 on the table 4.2 that I showed you, the guidelines are generally going to be managed perfectly well by their local palliative care teams. We're very familiar, obviously, with those. For patients in category 3 or 4, it may be a bit more of a specialist end-of-life care planning. Because that's something I didn't.
It was online.
Is it online? Okay. Yeah. So if CNH is withdrawn in otherwise stable patients, they're going to develop dehydration, multi-organ failure, usually uremia and electrolyte disturbance, resulting in cardiac arrest, normally 2 to 3 weeks. Families are often concerned about the mode of death, the length of the dying phase. It's a long time. They're worried about whether the patient will suffer hunger or thirst. They often ask about lethal injection. Most people say to me, I had a dog, I took them to the vet, they had a peaceful death, they died in my arms, can't you do that? Sadly, we can't, it's not legal in England. We can only provide optimal palliative care. So in many cases, actually, stopping CNH is not particularly distressing. We know that for people who've been through hunger strike. You may get a dry mouth, that can be managed with meticulous mouth care. But issues to be aware of include that many patients with brain injury have dysautonomia, or sympathetic storming as we call it. So they may have sweating, tachycardia, hyperventilation. If they've got spontaneous movements or vocalization, as many of them do, those may become more pronounced. And they can be distressed, it can appear distressed even though they're unaware. And that's a potential burden of witness. We need to anticipate and manage those symptoms. Families and care staff need to be warned that they may occur and be supported through the process. And we also need to remember that over the 2 to 3 weeks, people will visibly lose weight, and they may lose up to 1/3 of their body weight. That will also produce reduced tissue perfusion, so that that may affect the absorption of the subcutaneous medication. They may have an erratic response during the late stages, particularly to bolus doses. And for that reason, I prefer to use the intravenous route because it gives us better control, and overall we tend to use lower doses. So the protocol in the guidance has the sort of main principles that, even though it's probably not very distressing to die following CNH withdrawal, it's important for all concerned to be able to reassure them that the patient's not suffering. That includes the family, but also the treating team. So we provide anticipatory sedation and analgesia with the aim of keeping the patient in calm coma. We use the minimum dose, but we escalate as required. And there's a 4-stage protocol effectively delivered by intravenous or subcutaneous medication. Small dose to start off on the background for 24 hours. Bolus doses as required, which could be for predicted needs such as turning or breakthrough symptoms. And then we tot up the dose for the last 24 hours and re-prescribe that as background. And then when boluses are no longer effective, we move to the next stage. So the 4-stage protocol includes morphine midazolam to start, levomethasone if you're using subcutaneous route. Otherwise, for the IV, we tend to use IV phenobarb in low dose for stage 2, higher dose phenobarb, IV stage 3, and self-ventilating anesthesia, for which you do need to be delivered by an anaesthetist. It's important that we escalate doses appropriately to achieve control of symptoms, and we don't overdo it. But we also have to remember that patients with cortical damage tend to be quite resistant to standard sedative medications, and therefore the guidelines allow for higher doses that people are often used to seeing. And there's no evidence that that hastens death, provided they're titrated really carefully to symptoms. But if in doubt, people can seek advice. Just briefly, I'm not going to go through it in detail, the 4-stage protocol. As I say, we start with morphine and midazolam. At a low dose, we build it up, technically up to 100 milligrams per 24 hours, but we have to be careful about morphine induced agitation. So I'm normally looking to swap over at about 60-60 onto next stage 2. Subcutaneously, levomethrin can be used. We've had a number of really quite acute sort of respiratory based on stopping breathing with respiratory distress suppression with levomethrin. I prefer to have a low dose of phenobarb in stage 2. We titrate that up. Stage 3, higher doses of phenobarb, technically up to 2,400, but we can go up to 3,600. And only then, if we need it, stage 4. I've never had to go to stage 4, but I had a patient this week who was on the top of stage 3. So we do sometimes have to go there. But that said, the majority of patients can be managed on stage 1. A number of particularly challenging sort of situations we might come across. People with higher level MCS, so more aware, understanding of what's going on, but not really able to speak to them and find out how they're feeling. People on an emerging trajectory or have emerged. People with severe pain and distress or sympathetic storming. Sometimes religious beliefs, families wanting patients to be alert and with them at the end, which can be problematic, and they're requesting minimal sedation, which can be difficult. So we can look at some possible additional safeguards for helping us with the palliative care programme, and our palliative team at Norfolk Park are really helpful in that. We published our experience for an 8-year mortality review, which is published and available to look at if people are interested. So in the last 5 minutes, I just want to talk briefly about recent experience of a couple of court cases and what it actually means when one gets into this court scenario. I have to say it's very challenging, it's very stressful for everybody concerned, and it's really worth trying to do the best we can not have to go there by doing all of the process carefully, but sometimes you just can't resolve differences of opinion and you have to go to the court. And because we're seeing more of these best interest discussions happening more routinely, now we're having cases come through. So famous case GU, a man in the age, it was 70. He'd actually been in vegetative state for 7 years. Most of his family felt he wouldn't want to continue to live, but his son was determined that he would. So the treating institution just carried on anyway, because one of the family members objected. When it did get to the court, they were criticised for the delay in taking it to the court because it was disputed and it should have come earlier. And this is a theme really amongst the court. They're very keen for these cases to come early, possibly not always understanding what early means, and I'll come to that. GUP was a lady recently, a lady in her frail lady in her 80s, a nasogastric tube fell out, she couldn't be replaced despite multiple attempts. The judgment supported discontinuation of IV fluid and giving palliative care, but as over to dicta, which is other comments, Mr. Justice Hayden said, where there's a conflict in these serious medical treatment cases, it's in everybody's best interest, most importantly the patients, to bring an application to court. Now, nobody quite knew what he meant by that. He was actually framing it in the context of best interest, but it sounded like he was moving over into the clinical decision and saying even clinical decisions need to come to the Court of Protection, which is actually out with the Court of Protection's jurisdiction. So there's been a lot of debate about what that actually means. But I'm going to just explain 3 recent cases that we've had. We took them to the court as soon as it was evident, but these are patients who are moving quite fast in a deteriorating situation. And we had a very prolonged court process, which was hijacked by other issues than the CNH withdrawal. And it started to involve things that wouldn't normally come to the court. So case 1 was, by the way, these are cases in the public domain. I'm not breaking confidences here. Patient dying of respiratory failure due to chronic aspiration, no viable feeding route. We'd stopped the nasogastric feed because it was going straight into his lungs. Feeding wasn't on offer. His family wasn't accepting of that, and they accused the team of murder. We ended up with 7 consultants opining that sadly the patient was dying. We made an application to the court not to stop CNH because it was no longer an offer, but to stop giving IV fluid, which was prolonging his dying period, and give him palliative care instead, which the family was declining. We had an urgent referral to the court. The judge was new to the area. They allowed a gentleman for a month to seek other opinions. The official solicitor tried to get the court to order us to give total parenteral nutrition during that time. It was out with the Court of Protection's jurisdiction, and that wasn't given. But unfortunately, the palliative medication was minimised during that time because it was under scrutiny by the court. We ended up with 12 different consultants, and unusually, all 12 were unanimous that the patient was sadly dying. And unfortunately, he died unpalliated in considerable distress, really just as the judgment came through, so we couldn't put it into place. And the tragic thing was that his family spent precious hours that they could have been with him at the last days of his life in court. Indeed, they were still in court or waiting on the steps of the Court of Appeal when he sadly died. So very distressing and difficult situations. Case 2, a patient with MCS plus, quite high level of awareness, complex social background. His family was initially absolutely united he wouldn't want to live, and as a team we found that quite difficult because he was quite alert, but they were adamant. But then as we got towards that decision, his partner quite understandably hesitated, and she requested an application to the court for reassurance that it wasn't her decision, even though it wasn't her decision anyway, but she wanted that reassurance. So there's lengthy discussion between 3 legal teams. We had the official solicitor, the trust legal team, and the CCG's legal team. Eventually, we decided not to withdraw 2 pleadings because he was so medically unstable. It was felt that he was likely to succumb, and that would probably be a better way to end his life. But we did have a tight ceiling of treatment, so he wouldn't keep getting admitted to hospital, and that was ordered by the court. But the legal teams then got involved in discussing the wording over the treatment escalation plan, which wasn't that he's not for admission to hospital, he's not for CPR, he's not for antibiotics. It was, if he's unwell, it might not be in his best interest to give antibiotics. It probably would be in his best interest. Do you get the frame? Wasn't very clear what the treatment escalation plan was. So during this time, it was a year, £70,000 worth of legal fees, a year while we argued to and fro about what the wording should be on this treatment escalation plan, during which he had 3 blue light transfers to hospital for IV antibiotics, even though the principal has agreed that he shouldn't be going to hospital. There was a progressive deterioration within each admission, and eventually, sadly, he died unpalliated on a trolley in hospital A&E because the nurse on the floor was just not sure how to interpret this legal treatment escalation plan. So it was a very unsatisfactory situation where we'd moved away from our normal decision-making processes. One more case, Stephen, and then I'm done. So last case is a patient with hypoxic brain injury who bled out after a kidney pancreas transplant, and he was in a vegetative state. He had a tracheostomy, he had bowel dyskinesia. He was dying from aspiration and respiratory failure and uremia because his transplant was failing. He had spasticity, he had a lot of pain with pain scores of up to 10 to 11 out of 12. His family had very strong Christian beliefs and denied he was in prolonged disorder of consciousness, denied he was in pain, and were understandably given their faith praying for a miracle. But unfortunately, that miracle wasn't going to happen. So we went to the Court of Protection with 2 options. One is that we could move him to a nursing home on a palliative care programme where he'd probably have maybe 2 or 3 months, or we can actually stop CNH and give him a peaceful and dignified death within the unit. The initial hearing again came across a judge who was not so familiar with this area. Case was adjourned for another opinion for a month. By the second hearing, he deteriorated further, so there was no longer an option to move him to a nursing home because it wouldn't have been appropriate and the nursing home couldn't take him. So we only had the one option. So we requested inherent jurisdiction, which allows a court to intervene when there's no other avenue. And we requested that the court would make an order for palliative care to be given properly, because the family were very loath for us to give effective palliative care, but unfortunately that was refused. The OS's barrister, the official assistant barrister, argued that this patient had suffered a great deal of pain in his life and therefore would be happy to receive substandard palliative care, which is a slightly bizarre approach to take. But sadly, again, ultimately made no difference. He died unpalliated while we were still waiting for the judgment. And again, that family lost those valuable last moments in his last few days. So, in summary, we've got a problem with these court cases. I don't think the adversarial process is very helpful or fit for purpose for a variety of reasons. It polarizes viewpoints. We get a breakdown in relationship with the family and team. Court processes are very lengthy. Sometimes you pursue red herrings, trying to demand treatments aren't on offer. It takes an enormous amount of clinical time, and that's a huge stress on the clinical staff who aren't used to being in court. And it also takes time away from clinical care, and importantly, time away from families being with the patient for those last few days. It's incredibly expensive, and each case costs maybe between 70 to 100,000 pounds, all of which has to be borne by the treating unit. In theory, the court can respond quickly within 24 hours, but it does take a long time to prepare all the documentation. There's not much change out of a week by the time you've got all of the information and the witness statements done. So I think, and of course, as we've also said, the court process can't keep pace with these fast-moving cases. So going forward, I think we need to think about some alternatives. Don't know what they are. Panel of wise men, maybe. Appropriate funding, it's equivalent to legal aid. So it's a separate sort of funding stream, maybe capped fees, so that the costs are kept down, and clearer guidance to the strict legal argument, to the subject of the application, and not get sidetracked on these other things that aren't really part of the remit. So I hope that's some food for thought, and open to some questions and discussion.
Thanks very much, Lynne. That was really helpful and comprehensive view of the issues in this field. Do we have any questions in the room? First of all, we have Brendan. Can you unmute?
Can you hear me?
Yes, we can.
Fantastic. I'm just worried about our duty to relieve suffering, but allowing a court to adjourn a decision for a month whilst everybody continues, as you put it, with these two patients having a very poor death. That sits very uncomfortably with me. I'm a palliative medicine consultant down in Margate, and I work in secondary care. I wonder what your thoughts are on balancing our duty to relieve suffering, but when the answer comes back from the court, let's wait a month.
Yeah. I agree, and we took both of these cases very quickly. As soon as there was it became evident there was a disagreement, we made the application. It sits very uncomfortably with me too, and I don't think, as I said, that's why I think that the current process isn't really fit for purpose. Both cases, it met a judge who's never adjudicated one of these cases before and wasn't really sure what to do about it. And to some extent, I think it's an unfair thing to put to a judge, because if they're haven't really thought about this area, how can they take responsibility? Whereas we think about this area all the time, and we discuss it, and we have a team, and a multidisciplinary team of therapists, and it's not just the doctors, it's the nurses and the therapists and so on. So we think about it all the time, and I would argue, some of my legal colleagues might disagree, but I would argue we're better placed to make those judgments than the legal system. Not to say that legal system can be helpful sometimes to resolve some of these difficult disputes, but I think I agree with you. A journey for a month is completely inappropriate. We are in the process of doing the medical legal update of the PDOC guidelines, and we'll be highlighting some of these issues with them.
Great, really helpful to have your thoughts on that. Thank you very much.
The questions?
Can I pick up on that? And I hope I can be heard online. Yeah. I don't understand that. I don't understand the rationale. We don't need the court to tell us we're allowed to palliate someone. That can happen in parallel. I just don't get it.
Yeah.
Can you explain?
Well, So the problem is with these two cases where the family was not accepting the diagnosis and not accepting palliative care. They were calling the staff murderers and physically stopping them from giving the palliative treatment and medication. Now, we could say, well, it's our duty of care. We do need to palliate. It's a best interest decision, and we should. And then until the court tells us they can't do it, then we should be doing it. But the problem is with that is that when the nurses staff in particular are faced with giving something on the ward, at some point they're going to give that last dose. The family is going to say, "But you killed this patient," and yeah, that's an intolerable burden to put on staff. So in both cases we asked for palliation to be approved by the court while we waited, but in both cases it was fudged to the extent, well, minimal palliative medication, because you can't. It was assumed that we were going to try and hasten the process, which of course we weren't.
But in a way, that perpetuates the problem, because you're sort of saying we need to ask the court if this is all right, and we shouldn't need to ask the court that at all. No. And I see it as well in clinical practice, increasing levels of distrust about what palliative care is. People thinking it means killing you, and I'm very worried about it.
Well, I think it's right, and then I think also the wording that the court uses, and again I think this needs sort of reviewing. The wording the court of protection uses is it would not be unlawful to. It doesn't say it's lawful to. It said it would not be unlawful to do, which means just doesn't really give us any protection.
Rachel, on Thorpe online, do you want to ask your question on mute?
Yes, thank you. It's just to follow on from the previous question, and I was wondering if with any of these difficult cases the palliative care teams become involved. We're often in the hospital I work come along to meet with families around patients who are in, not the same but similar scenarios, to make early contact, and there's this concept of parallel planning, which allows the active care to run alongside the supportive and symptom focused care, and the palliative care teams can answer and address all of those probably incorrect fears that families have, because we all know and can confidently say that what we are going to give that patient for their symptoms is not going to kill them and is not going to hasten their death, and sometimes we just actually have to address those. And I wonder if sometimes involving palliative care teams in a supportive parallel planning way, rather than they're just going to come in and finish off the patient or hasten their death, might be another way around these standoffs.
I think that's a really important point. We're terribly fortunate at Norfolk Park because literally our palliative care team is right at the end of our ward, and so they do get involved. We routinely get involved, not only just in the end of life care, but in the decision making process. So we involve them from early on. And although I presented, if you like, the bad cases, those are just sort of two. I would say that we do unfortunately have many of these cases, not only the ones where we make the elective decision to withdraw CNH, but where we literally have unsurvivable brain injury and managing an inevitable death. So we do end up having most of those cases. If there's uncertainty amongst the family, it gets resolved through that really supportive palliative care input. And our palliative care team are absolutely fabulous. Not just the doctors, they're fabulous too, but the nurses as well. They come up every day and they keep that gentle process going with the families. And mostly we manage without the need for the court. I hasten to add. And I think we manage it well. There's the data's in the paper that I had for the mortality review over 8 years. I think there were 80 deaths. We only withdrew CNH, I think, in 14 of those electively over the years. But we withdrew CNH in about half of them because we couldn't give it, or it was inappropriate to give, and also the palliative care.
Thank you, Lynn. One last question.
I was wondering if we could go back to the discussion about best interests decision making. And I saw this thing on the side that was really interesting where it said next of kin don't have superior powers and instead we should consult the relevant people. I was wondering, how do we who defines who are the relevant people? Like, where is the limit to how many family carers are involved and whose input is valid?
It's a very good question, that. And to be honest, we can get all sorts. The next of kin is really just, it has no legal basis. It just is a conduit for communication between the team and the rest of the family, however narrow or wide that circle is. And sometimes people do it better than others. But we have had the scenario where we've had somebody who's dying and people have turned up. It's not only the wife and the family, but a mistress or two and their families. And we have a large number of people around the room, some of whom didn't know the others existed. I have to say, so sometimes that the number can get big. I think the biggest meeting that I've had was 21 people, all of whom wanted to be involved and have their say. I just welcome that the input. It's hard to manage that number, but I think it's really important to hear what people are saying. It gives you confidence that if everybody's saying the same thing, they're not saying anything different. But sometimes they are saying different things, and then we have to weigh that up. But it isn't the question that one family member disagrees, so we go to court. We work to find out why it is they do that. What are their beliefs? What are they thinking? Sometimes somebody's own beliefs, or they're hoping for a recovery. They haven't really been involved in the discussion, so they're not quite sure, what the patient's underlying problem is. All of that we work through, but we do have some quite extended families, and we do have some quite exciting best interest discussions, I'd say.
Okay, thank you very much, Lynne. Thank you to everybody in the room and those online too.